Good evening and welcome to our webinar on advances in pain management. I'm Dr. Jessica Jameson.
And I'm Dr. Joe Kent.
And we are the interventional pain physicians at Access Spine Center. And we're going to go through a lot of stuff tonight. It'll be kind of a great amount of volume. And at the end, we're going to ask you for some questions. So if you have questions, there's a question and answer, or there's a question box or chat box that you can ask questions to. And then when we get to the end, hopefully we'll be able to get to most of those questions. So without further ado, let's talk a little bit about the recent advances that we've seen in pain management. So our objectives tonight are really to discuss kind of the previous ways that we've managed pain. We've been doing pain management for many, many years, and we've got a lot of kind of tools in the quiver that I think can be really helpful, but some of them have some significant drawbacks that we'll talk about as well. And then we'll discuss the current novel therapies to manage chronic pain and some of the indications for those things, as well as a little bit on further research that's going on and then some promising frontiers. So first, let's talk a little bit about our typical tools to manage pain. We're all very familiar with the use of NSAIDs, non-steroidal anti-inflammatory medications. There's adjuvant medications, which are things like gabapentin, Neurontin, nerve-type medicines. There's opioids, which we put a little question by because as we've been hearing lately, not only do we have an opioid crisis, but there's very little evidence for the use of opioids in managing chronic pain. We have physical therapy, we have chiropractic care, we have things like steroid injections, ablations, spinal cord stimulation, and intrathecal pain pumps. But then let's talk a little bit about some of the problems or drawbacks that can be associated with these. NSAIDs can cause problems with kidneys, bleeding, stomach issues. Adjuvant medications tend to have side effects that go with them. A lot of times people feel sleepy, they have numbness and tingling kind of in their fingers. Opioids, as we discussed previously, there's not a lot of evidence for long-term use, and we also worry quite a bit about addiction and dependence. Physical therapy, chiropractic care, sometimes there's a lack of follow-through on that. And patients will attend these things and get some relief, but then sort of forget to do their ongoing physical therapy or their home exercise programs, which is really where the long-term benefit is. Steroid injections, we worry about osteoporosis. Sometimes we worry about adrenal suppression. We're pretty careful about that here at Access Spine, and I think within the field as a whole. And we try very hard to keep the steroid dose under a certain amount in a 12-month time frame. Ablation is only for sensory nerves, so I think we hear a lot about people talking about ablation or this kind of heating the nerves, but you can only do that for sensory nerves. So you can't do that for the nerve that goes down your leg, or you won't be able to walk. Spinal cord stimulation. Previous systems were really hard to capture back and neck pain, and the next slide will talk a little bit more about the new spinal cord stimulation changes, which are very different from the old systems that we've seen in the past. And then intrathecal pain pumps. It's still an opioid medication. So while that has a role and can be very helpful, it is still an opioid medication. So tonight we're going to talk about some of these new and updated therapies to treat chronic pain conditions. We'll talk about spinal cord stimulation. We'll talk a little bit about peripheral nerve stimulation and what that is and who that can be used for. We'll talk about a relatively new form of stimulation called dorsal root ganglion. We'll talk about multifidus stimulation. We'll talk about indirect spinal decompression, as well as percutaneous image-guided lumbar decompression. Then we'll move on to a little bit on regenerative medicine and some new changes that have happened there even in the last 2 weeks. And we'll talk about basivertebral nerve ablation. So spinal cord stimulation has been around since the late 70s, was when the first system was implanted. But over the last 5 to 10 years, the technology has changed so much that it doesn't even compare to the old versions. It's primarily indicated for patients who have had back surgery and still have back, leg, neck, or arm pain. What I tell patients is that it's a really great opportunity to try something out for 7 days. You don't really get a chance to try out your spine fusion, but you get a chance to try out spinal cord stimulation. The permanent implantation of the device is an outpatient procedure. You go home the same day. And there's quite a bit of evidence that shows that we can decrease patients' pain medication requirements using these devices. There's 2-year evidence now for decreased pain medicine, as well as improving pain scores and function, which is something that is really important to us here at Access Spine Center. We still will ask you about your pain score, but what we really want to know is, how has your function changed? Have we done something that has allowed you to participate in life more? The basic premise of spinal cord stimulation is that there are two small wires that are put into the back, and we put them into the back the same way we would do an injection. So it's an epidural placement. For the trial period, we then tape them to the skin. And we give you a little fanny pack to go around with for about 5 to 7 days to see how much better you feel from that. And that's how we make the decision about the permanent implantation. The wires are connected to a battery. During the trial, there's an external battery that's in that little fanny pack. And the wires then buzz. And that buzzing sensation travels on really fast nerves. And pain sensation travels on slow nerves. And the brain can't really handle two inputs. So it shuts the door to kind of the pain signal. So while we're not changing the underlying condition, what we're changing is your body's or your brain's response to the pain. So it's sort of like white noise for the brain is kind of a good way to think about it. There are multiple different companies that make these devices. All of them have their indications for specific pain patterns, specific things. But really, it's an excellent therapy that has a lot of long-term evidence for improving pain scores and quality of life, and for also decreasing reliance on opioid medication.
And now we're going to talk about peripheral nerve stimulation, which is similar to spinal cord stimulation, but the target is going to be a little bit different. And so what peripheral nerve stimulation is basically using the similar type device, but instead of placing it along the spinal cord, we put it along the nerve that's affected. It's there are a number of conditions that this can treat, and really, here are a few of them: ilioinguinal neuralgia, after a hernia surgery, intercostal neuralgia after a rib fractures or a rib surgery, where they're going in through the thorax. Occipital neuralgia is a big one that can be difficult to treat. And so what I tell patients is if we can identify a nerve that's damaged, then it should respond to peripheral nerve stimulation. And so what we'll do is, and this is just a few pictures of that right here, where you can see in this bottom left is basically peripheral nerve stimulator targeting a knee that is continued to be painful after a knee replacement surgery. As we do know, about 20% of patients still have some sort of knee pain after a knee replacement. For this middle picture, you can see what looks to be like a target of the ulnar nerve for basically nerve pain affecting the hand. And so it's kind of fun, well, not fun, but it's nice to, as there's a lot of possibilities with peripheral nerve stimulation. So if you can identify the nerve using ultrasound, then or fluoroscopy, then you can basically block the pain signals in those nerves. The peripheral nerves themselves, they are conditionally MRI compatible. It is similar to the spinal cord stimulator, where you try it before you test it. Typically, what I will do is I will first see, by blocking that nerve with a local anesthetic, using typically ultrasound, but sometimes fluoroscopy, if that covers the area of the pain. If it does, then typically we'll talk about moving towards a trial period where you will again test the device for a period of time to see, again, will that manage the pain? If it does, then basically it's another outpatient surgical procedure. And what that will do is basically, instead of having the device come outside the skin, that small little wire will be buried underneath the skin to manage your pain for the long term. And so, like I said, that can be a very effective way to treat chronic nerve-related pain after an injury or a surgery.
So now we'll move into a different form of stimulation, which is relatively new, I would say, called dorsal root ganglion stimulation, which is just a fancy word for the location of the electrodes in the wire. This is indicated for chronic pain over 6 months, and really where the bulk of the evidence is for this therapy is pain in the lower part of the body, such as the foot, the knee, the hip, the groin, that's following either an injury or a surgical procedure. So again, this is something that could be used for pain after total joints as well. It's MRI conditional, and again, similar to spinal cord stimulation, peripheral nerve stimulation, dorsal root ganglion stimulation allows you to have this 7-day trial period before the permanent implantation goes in. And so really, dorsal root ganglion stimulation is a form of spinal cord stimulation, but it's a bit more targeted. It's a simple 3-part system that's used, and you can see in this bottom picture here that the little black dots are these electrodes that come out. The foramen is what we call it, and sometimes we'll talk about the foramen as being where the nerve comes out of the spine and then goes down the leg. There's a generator, and that's the battery. There's the leads. That's what we've been talking about, these little dark spots here. And then there's a patient controller, and that's a handheld remote control that allows you to adjust the strength of the stimulation or even turn the stimulation off. And this part is not unique to dorsal root ganglion stimulation. Spinal cord stimulation and peripheral nerve stimulation both have a patient controller. So you're able to turn it up, turn it down, turn it off, change programs. Lots of different options from a patient controlled standpoint with that.
The next thing we're going to talk about is using stimulation, but the goal of the stimulation is going to be different, and that's with multifidus stimulation, or this reactivate system. This is a newer technology that is basically just recently making its way into the United States. It's been around in Europe for a long period of time, where they've done a lot of these initial studies. But the goal, unlike with some of these other stimulators, is blocking the nerve pain. The goal of this device is to basically, how I like to think about it, is an internal physical therapy, if you will. And so what it's used for is, patients with pain for more than 3 months, they've not had a back surgery, they're not a candidate for back surgery. So when a surgeon or, we look at your MRI, there isn't any nerves being pinched anywhere. And they continue to have what we call mechanical back pain, or back pain that's isolated to the middle of the low back. That's worse, when you use your back. What this involves is, again, it's an implanted device. It goes in a very certain area. And what it will do is stimulate these small multifidus muscles, which are muscles that connect the different segments of the spinal column. And it will work on strengthening these muscles to help with overall stability of the spine. What's involved, and we'll talk a little bit about the studies here in a minute, but what is involved is having basically 30 minutes of stimulation for twice a day. And this is going to go on for months. And what we'll see is, kind of like with physical therapy, there will be a gradual improvement in symptoms. The one reason that this is such a promising and exciting therapy is, when you see a physical therapist, they're going to be doing a lot of things to help strengthen your back muscles, but they can't focus on these specific tiny muscles that have been shown to be very important with spinal stabilization. Because when they're working on strengthening these muscles, they can't isolate these big, large muscle groups in your back to just focus on these small muscles. And so this device has the promise to basically strengthen those smaller muscles. What it is involved with is, you can see this picture is, again, there's a small little battery and these little leads going right across around the L3 transverse process. And basically what it does is it just sits along those muscle groups and delivers energy at a certain frequency for 30 minutes, like I said, twice a day, to strengthen those muscles. And what they found in their study is, when they were looking at it, and this year data is up to 1 year, but they now have, I believe, up to 3 years or at least up to 2 years of data, which shows a substantial increase in patients' back pain. Seeing about a 50 to 60% reduction, up to 1 year. This was improved, showed improvement as well as with your ODI, which is basically a marker of how disabled or how functionally disabled patients are. And then there's this on the far right, you'll see this EQ5D, which is how many patients felt like this procedure was clinically important. And so that's big when we're talking to our patients, because we want pain to be better, we want function to be better, but we also, having that kind of that feeling that you are improving is big. And over 80% of patients at 1 year for mechanical low back pain where there isn't a surgical option, this is phenomenal results. And so that'll be something that we're going to start looking at doing here shortly. Moving on to the next one. Dr. Jameson, after her coughing fit, is back.
This is not a good time to have coughing fits, is it? Sorry about that. So let's move on and talk a little bit about this, what we call indirect spinal decompression for lumbar spinal stenosis. So when we talk about lumbar spinal stenosis, what we're referring to for this particular therapy is something called neurogenic intermittent claudication, which essentially means pain in the back and legs, or sometimes numbness, tingling, or a heaviness feeling that seems to get worse when you walk, better when you sit down or when you lean forward. So patients with this are eligible for this therapy if they have been symptomatic and unresponsive to conservative care in the form of our typical things that we usually think of, which is physical therapy, sometimes injection therapy, for at least 6 months. It's indicated at no more than 2 adjacent levels. So oftentimes we'll have patients come in who have a desire to be considered for this therapy, but really have 4 levels of really bad stenosis. Those patients are not great candidates for this procedure. This is a picture of the device itself. It's called Superion Vertiflex. And it looks like the top picture there is kind of in the closed location or the closed position, and the bottom picture is in the open position. And you can see that it goes right in between those bones of the spine. And what it really does is it prevents you from being able to extend back. Now, you don't notice any decrease in your function, flexibility, movement with this device, but it prevents it enough that you're not closing off the spine and creating more of that neurogenic claudication. This particular company had a very large trial with 470 patients at 29 sites with 24-month follow-up, and then annually followed up those patients all the way through that 60-month or 5-year mark. And the data suggests pretty clearly that patients typically had significant relief from their symptoms of spinal stenosis and very high satisfaction. I like to joke that the patient satisfaction all the way out at 60 months is 90%. Ain't nothing I do that gives 90% satisfaction at 5 years. I can tell you that much. So we kind of joke about that because that's a pretty robust response for patients. And, you know, to have 90% of patients who are really happy with their decision to undergo this procedure is pretty remarkable.
So another way to address spinal stenosis, just like an indirect decompression, which I guess we're still on.
Here's the picture. Here's the X-ray pictures of this Vertiflex. Looks like these cute little spiders in there. But then let's move on to this percutaneous.
This is what I was talking about.
Yeah.
So this is similar to, so the reason we do an indirect lumbar decompression is for a similar reason why we do this procedure, which is a percutaneous image-guided lumbar decompression. The small, you know, the acronym is MILD. And what it is for spinal stenosis of the lumbar spine. And so you can see kind of some of the symptoms that you can find here, you know, more likely to happen, you know, once you reach those golden years at 60 plus. They can mess with your mobility, quality of life, feeling like you have to sit or, you know, lie down, lean forward more frequently. And usually these are patients who have, you know, failed a number of different therapies. And what the device is, essentially, is when you have spinal stenosis, you have narrowing of the spinal cord itself. And part of that, that can be from a number of causes. It can be from your discs, can be bulged out, that's usually a component. Your facet joints, which are these paired joints in the back of your spine, can be enlarged from basically arthritis. And then you have this ligament, which is basically a, you know, strong connective tissue that sits in right behind this where the spinal cord is sitting. And when people get arthritis, that is more likely to get enlarged, and that also contributes to spinal stenosis or narrowing of the spinal cord. And so what this device is it's basically putting a small little grasper tool to basically remove some of that extra ligament tissue and to remove a little bit of bone to create more space around those nerves. And so it's not, you know, a large laminectomy for like you'd see, you know, get from a surgeon, but this is a, you know, a small minimally invasive device where you're basically taking out just a small amount of tissue to open up the space around those nerves. The data behind it is very good. They have 2 level 1 randomized controlled trials, which is the highest degree, you know, as far as, you know, when you talk about trials, that's the gold standard. And both of those, with over 30,000 patients, you know, showed a clinically meaningful improvement in pain and mobility. And what, you know, typically for pain literature, you're looking at greater than a 50% pain relief. And then what they also found, which is just as important, is it's just as safe as an epidural steroid injection. If you've ever seen a pain doctor, there's a good chance at some point you've had an epidural steroid injection. It's a very safe procedure. And so what they found is this minimally invasive procedure that can actually take out some tissue around those nerves to open up the space around those nerves is just as safe as an epidural steroid injection. This was a Cleveland Clinic study, so over in Ohio, and what they found was that looking at standing time and walking distances, which is two of the things that patients with spinal stenosis tend to struggle with. They had a 7 times improvement looking at from baseline all the way up into month 12 of standing time, and then a 16 times improvement in walking distance. And so for a lot of patients, that's a big deal. If they're able to walk with their family members, walk their dog, walk around the neighborhood, stand and talk to neighbors, I mean, that's a big deal. And so this therapy is definitely very, very meaningful for a lot of patients. It is an outpatient procedure. It's done just in basically a procedure room. The incision is very, very small. And this is oftentimes we're going to be looking at patients who are not great candidates for larger spinal surgeries. So patients with other comorbidities, problems with the heart, that type of thing, or going through a big spine surgery isn't an option. This is going to be a safe and effective way to treat spinal stenosis.
And then now let's move on a little bit to regenerative medicine. And this could be an entire 2-hour topic in and of itself. But for sake of time, we'll talk a little bit about bone marrow concentrate, which we take from the hip. It's best for large joints. Platelet-rich plasma, also known as PRP, which is taking your own blood and then spinning it down, separating the platelet-rich plasma and injecting that back in, typically for tendons, ligaments, and some joints. That's the basic premise, and there's variable evidence for these things. Now, typically regenerative medicine is not something that is covered by insurance. And so because of that, there's a wide variety of outcomes and of the stuff that's used. You'll hear a lot about umbilical cord things. You'll hear a lot about amniotic fluid things. So again, this could be a 2-hour topic in and of itself, which we will do at some point on one of our quarterly webinars. But typically this is not covered by insurance. And so what's exciting is that we've had something that is quite regenerative, which has become covered by Medicare as of January 1st of this year, and that's this product called ViaDisc. And so it's for discogenic back pain. So discogenic back pain is a pretty specific set of symptoms. So that's going to be typically midline back pain. It's not typically going to radiate down to your legs or your feet. It's oftentimes worse if you sit down, worse if you cough, these sort of things. And it comes as a result of the degeneration that happens with age. I usually say about the age of 30, it's all downhill from there. Your discs lose water, they become more like raisins than grapes, and sometimes, not always, sometimes they become painful. So this substance is injected into the disc itself. It's derived from donor discs, which means cadaver discs, and injected via a 22 gauge needle, which is a pretty small needle. So that essentially, the needle goes into the disc itself, and the substance is deposited there. And a lot of their testing shows that the hydration properties of this substance are very similar to the center of our regular discs called the nucleus pulposus. It's a non-surgical, so again, it is an outpatient procedure that's done typically with a little bit of sedation. And this diagram, I think, shows wonderfully the age-related wear and tear of the disc, and that causes loss of hydration and what we call degeneration. So patients come in and they say, "Oh, doc, I've got degenerative disc disease." And we get frustrated because it's not a disease. Everybody has it, right? So after the age of 30, maybe even younger, the discs just gradually start to lose water. So by definition, you have degenerative disc disease if you have loss of water of your discs, which we will see on almost all, if not all, of the MRIs that we look at on a daily basis. And it does not always cause pain. In fact, I would argue that it's the minority of patients with that condition that actually have pain from it. So this middle picture shows the ViaDisc that gets injected into the intravertebral disc through this spine needle. And then after the injection, what the ViaDisc does is it sort of supplements the degenerated intravertebral disc. So it gives it a little bit more strength and resilience than it had previous to this. Again, they have good long-term 2-year data. And this is, for us, this is very exciting because these patients who really have pain from their discs are a difficult population to treat because we don't have a lot of options for them. We really haven't figured out how to make that pain better. You'll hear about things like people will tell you their horror stories about discography to identify if it's a painful disc, and then sometimes they'll go on to disc replacement, although that's really not done very often in the lumbar spine in this country for multiple reasons. Sometimes patients will have a painful disc and then end up having a fusion, and then ultimately down the line you can have the problems that are associated with that as well. And as with any of these big surgeries, there's 15 to 20% of patients who are still going to have pain following that surgery. So this is a really exciting and promising thing for us because it gives us something that is covered by insurance or will be covered by insurance eventually, that can really help patients in an otherwise really difficult to treat patient population.
All right, and I think this is one of the last topics we're going to talk about, but this is something that's also very promising. It's basivertebral nerve ablation. So a lot of people have probably heard about ablations. Dr. Jameson talked about it a little bit earlier, that a lot of times it's for sensory nerves. And for this case, it's also for a sensory nerve. But what's a little bit different is this sensory nerve is basically inside the bone of the vertebral body in the spine. And it takes pain signals basically from that vertebral body and the end plates around up above and below that vertebral body. And so for this procedure, what we're looking at on the MRI is this upper right-hand picture, where we're seeing basically some changes around the disc, and those kind of white changes around the disc are signs of basically inflammation or irritation of that bone, and that can be, a pain generator. Part of coming to a fellowship-trained pain doctor is we're going to try to identify all the various aspects of your pain, not just the things that are, radiologist writes on his report. And so this is one of the things that we look at, does your pain fit with this vertebrogenic edema or vertebrogenic pain? And so if it does, one of the procedures that's been used very successfully is basically ablating or doing a procedure to burn that nerve to the bone that is inflamed. And that is, typically for patients who have failed, a lot of conservative treatments, for 6 months or so. These modic changes are those changes that we just talked about on the MRI. And it is it's a minimally invasive procedure done all outpatient. It's basically just heat up the nerve and basically stop it from functioning. It is very safe, and we have long-term data, 5 years, looking at how well it works for patients with basically midline low back pain from inflammation of these bones. And so this is also, again, another great therapy that we're able to offer here at Access Spine.
So a quick, just sort of 2 seconds on the research studies that we have ongoing here at Access Spine Center. We're involved in multiple clinical trials, and really the purpose for us is to be able to offer otherwise things that may not be available to our patients in a safe and controlled manner. And so right now we've got a couple different studies going on. We've got a spinal cord stimulation for non-surgical back pain. So for people who have been told, that you're not a candidate for surgery, but you still have back pain, we're doing a study for that. There's a new type of spinal cord stimulation that again has been present in Europe for many years, but is just now kind of coming over to the United States, and we're doing a trial on that as well. We're tracking outcomes with the Verteflex, or that indirect decompression. And then we've got another study on sacroiliac joint fusion. So if you're interested in any of those, you can give us a call and we can kind of tell you whether or not you might fit with those.
So just a conclusion, we talked about a number of different therapies. In pain medicine, there's a lot of things that are evolving and changing with time, especially as we get better at identifying different areas of the body that can cause pain. So just to recap what we talked about, we talked about 3 different stimulation therapies, primarily for nerve-related pain, and that's the spinal cord stimulation, the peripheral nerve stimulation, which is pain usually in the extremities, and then this special dorsal root ganglion stimulation, which is a form of spinal cord stimulation. We also talked a little bit about multifidus stimulation, which is similar in that you're stimulating tissues, but for multifidus stimulation, it's going to be more to stabilize the spinal musculature to prevent any shifting of the spine and kind of really regain some of the strength of the spinal column itself. We also talked about a couple of different ways that we can treat spinal stenosis, which is a big problem for patients as we get, as people get older, and that can be done both indirectly using an extension blocker called Verteflex, or using a small image-guided, minimally invasive lumbar decompression to basically take out a little bit of the tissue that's causing the stenosis. And then we also talked a little bit about regenerative medicine, and specifically this new ViaDisc therapy, which has been approved by Medicare, to basically rehydrate or give you more cushion for those discs in your back. And then the final thing we talked about is this basivertebral nerve ablation, which is great for pain coming from the bones of the bones of the low back specifically. So I guess at that point we will open it up for questions.
Todd would like to know, hear about treatments for pinched nerves.
Okay, I'm not sure if everyone heard that. So Todd would like to know about treatments for pinched nerves. Well, depends on what's causing the pinched nerve. That's a good politician's answer, isn't it? So pinched nerves can come from a variety of things. As Dr. Kent was mentioning, sometimes you'll have a disc that's putting pressure on the nerves. Sometimes those facet joints at the back of the spine will be enlarged and put pressure on the nerves. Most of the time, it's a combination of these things. It's usually not just one thing that's causing pressure on the nerves. If you've got pressure on the nerves, the classic symptoms from that are going to be back or neck pain that radiates into the arm or the leg. Treatments for that are a variety of things. If you have a disc sitting on a nerve root and not much else happening in your back, and we do nothing for you, chances are you'll get better in 6 weeks, even if we do nothing for you. But we can make it a lot faster and a lot less painful of a recovery if we can do things like chiropractic care, physical therapy, targeted steroid injections. Again, that's a really great use for steroid because it does a couple things. It decreases the inflammation, but then steroids also act preferentially on the C fibers of nerves, and those are the fibers of the nerves that send pain signals to the brain. And so we can decrease the pain that way with injections. If that's not helpful, we can send you to our surgical colleagues to say, hey, is there something from a structural standpoint that we can make better by doing surgery? If the answer to that is no, then we can come back and consider other advanced procedures like some of these spinal cord stimulation type things.
The next one is Catherine is wondering, we have a picture of spinal decompression. I don't know if it was put in the...
Yeah, let me, I don't think we have the minimally invasive lumbar decompression. Let's see if I can find a picture of an MRI.
I'll grab it.
Yeah.
Hang on, Catherine, I got it.
Yeah, we're gonna grab something real quick, but we don't have a great picture of the MRI here.
Oh, it's aggressive. Now I'm breaking it up. So I have to start here.
We're able to see on here.
So here, I can put it right here. You can see that.
All right, Catherine, I'll come over here. So you can see this is a picture of basically the spinal cord. So this is in cross section. And so this would be the back of your back. And this would be towards the stomach. And you can see that what can happen with spinal stenosis, there's enlargement of this bulging disc. There's enlargement of these joints on either side. And then you can get this enlarged, what's called ligamentum flavum. And that's that special ligament that sits right behind the spinal cord. And when you get arthritis or as your spine ages, that can become enlarged. And usually it's a combination of those things that causes narrowing of the spinal cord here, which causes symptoms of spinal stenosis or pain when you're standing, walking, doing things. Gets better when you sit down or lean forward. And so what the procedure, the mild procedure can do, actually, let's just leave there, is it's basically taking a small instrument with a little kind of claw at the end and basically taking a small bite or a small chunk out of this little bone right here and then taking out some of this tissue to create space around those nerves. And so that's what the minimally invasive lumbar decompression would entail.
All right. Okay, and then John would like to know if Axis Spine does any total joint replacement surgeries, i.e. the top system or Superion implants for someone 70 years old.
The short answer is yes. I think what you're referring to with that top study is facet replacement. And so that's a study that's going on. It's where the patients are randomized to our traditional fusion that you would have for your back, or this total facet replacement. And that study is still ongoing. And so that is something that our surgical partners are taking part in. So that would be an option. And then this Superion or Vertiflex is what we talked about here with this indirect lumbar decompression. And we certainly offer that quite a bit here.
No age requirements.
Okay. And let's see, the next question is, are there any treatments, from Nancy, are there any treatments for cervical facet joint to improve mobility and stop the pain instead of fusion, injections, or RFA? In other words, any rebuilding of the facet joint, like some tissue substance for an artificial joint?
So for the cervical spine, we are kind of limited on the therapies we can offer, as far as, a lot of the things we're talking about here is, while some of it can be used in the cervical spine, such as stimulation, the various decompression devices, the minimally invasive lumbar decompression, all that stuff is only indicated for the lumbar spine. And so we don't have those options for the cervical spine. As far as, facet joint or arthritis related pain, usually, the best surgeries typically aren't a great answer for pain from arthritis in the neck, because it just causes more arthritis of the neck. And so typically surgeons won't offer surgery just for arthritis related neck pain. Epidural steroid injections are kind of targeting a different thing. Those are going to be targeting more the spinal cord and the spinal nerves themselves. So those, again, not likely to help facet or arthritis related neck pain. And so then we start talking about, radio frequency ablations, and those are really the gold standard as far as therapy or treatment options for neck associated or arthritis associated neck pain. And so, yeah, we don't have a whole lot of other options other than ablation for arthritis of the neck.
Larry is asking, can you do anything for peripheral neuropathy?
Excellent question. So peripheral neuropathy is another, specifically, I guess, diabetic peripheral neuropathy, which, there are multiple kinds of peripheral neuropathy. The most common kind is diabetic peripheral neuropathy, but you can have idiopathic peripheral neuropathy, which means we don't know what's causing it, but you have peripheral neuropathy. And so it's also can be a very debilitating and painful thing that we don't have a lot of options for. So our typical options in our quiver include things like gabapentin, Neurontin, sometimes very low dose opioids, these sort of things. But from an interventional standpoint, there was recently 12-month data that was released, actually, I think this past weekend, the 12-month data came out on using a specific kind of spinal cord stimulation for peripheral neuropathy. And they showed greater than 60% of patients had 80% relief of their peripheral neuropathy. And the other thing that came out in that study was that the investigators noticed some changes in sensation in people's peripheral neuropathy as well, which we really can't explain, but is very exciting to look into. So the short answer there is yes, peripheral neuropathy is something that we actually have some good options for now, which is also pretty exciting.
Jody is asking, can any or all of these apply to the neck as well? I have 5 compressed discs in my neck with arthritis.
Yeah, so that's a great question. And so there are a few things that can be used in the neck when we're talking about these type of therapies, and we're mostly looking at spinal cord stimulation. Potentially regenerative medicine, if you're talking about, I guess getting back to the last question, that can be something that can be helpful for facet related neck pain. It would be, PRP or, bone marrow stem cell injections for facet mediated pain. But the rest of these therapies are only indicated for the lumbar spine. And so these wouldn't necessarily apply to neck related pain. When you talk about multiple compressed discs, compressed discs, again, we hear that a lot of time from patients, and that doesn't necessarily mean those are causing the symptoms. It really comes down to, are those compressed discs pushing on nerves, especially in the neck, when they're not carrying, a lot of the load for the whole entire body. And so, yes, some of these things may be helpful for that, but it would kind of depend on your specific situation.
Okay, and Jay's asking, or comment, pins and needles in the bottom of feet from neuropathy from chemo.
Oh, as the cause for the
As the
peripheral
question,
neuropathy. Yeah, so, I think that, so the data that we were just referring to is specifically on diabetic peripheral neuropathy. And so anything that we would talk about for other causes of peripheral neuropathy would technically be off-label. And even for diabetic peripheral neuropathy right now, spinal cord stimulation, well, I guess it's not technically off-label, but it would be, we don't have the data, basically. What I would say is the beauty of that therapy is you get to try it for 7 days. And there's really, it's very low risk to try spinal cord stimulation. And the payoff has potential to be quite significant, especially for neuropathic nerve pain of the extremities.
I think that's what's nice about a lot of what we offer is a lot of what we offer is reversible. And so if it doesn't help, well, no harm, no foul. There's a lot of these things that we also offer is very safe. They're very safe. And so the chance of having any, permanent neurologic or, permanent anatomic injury is so low that, oftentimes, these are things that we can try, given your situation, your imaging, the whole picture, to help with the pain. But one of the benefits from a lot of the therapies we offer is it's not something that can be, the complications are usually not there like you would see with a larger surgery.
Is there a limitation to the number of discs that VIA disc can be injected into?
I wouldn't think so. But
there's not, but I think what we typically find is that it's pretty rare that you have 5 painful discs. It's usually that you have 1 or 2 painful discs. And so prior to that procedure, what we would do is a procedure to try to figure out if the disc is in fact painful. So we would do provocative discography to say, hey, is this disc reproducing your pain? If I put a little bit of pressure in this disc, is that your pain? Because again, even though we can look at a spine and see every single level has degenerative discs, it's extremely uncommon that every single level is causing the pain. So the typical use for VIA disc and for any other substance into the disc is 1 or 2 discs.
Catherine is asking, can you do the disc regeneration with the minimal invasive space surgery?
If you had a and this is like with the Vertiflex device, I believe is what you're referring to,
or even the
it doesn't
Yeah.
specify.
And so so if you had pain that was associated with both the disc and the central stenosis or the nerves being pinched in your back, then potentially that would be an option. And while that may be the case, the more likely cause for the pain is going to be from the pinched nerves, less likely to be from the disc. And so what we would probably do is we would look at treating those nerves first. And then depending on the results of that, and if that helps some of the pain, but some of the other pain remained, and that was consistent with discogenic or pain coming from that disc, and that could potentially be a therapy.
And I think I would add to that remember that usually discs aren't painful. In fact, for many, many years, we used to say discs don't cause pain. They just can't cause pain. And it's only been relatively recently that we've said, okay, there are a very small percentage of discs that can cause pain. So just because the disc is degenerated or is compressed doesn't necessarily mean, and probably more often than not means it's probably not the source of the pain. So it's pretty rare that it is the actual source of the pain. And so prior to assessing that, we'll usually try to rule out these other things that we see on the MRI as being the cause of the pain.
Okay. And Patricia is asking, she's saying 8-year history of ruptured disc without surgical intervention, resulting in periodic leg and groin pain, disability. Is a possible dorsal root stim possible help?
I think we'd have to take a look at do an evaluation, because when you talk about groin and back pain, there can be a number of causes, and it's nice to try to fit everything into one specific cause, but oftentimes people have multiple reasons for pain, and so that's why groin pain can be associated with nerve, that L1 nerve, especially if you had prior hernia surgery or that type of thing. Or groin pain can very often be a symptom of hip pathology. And so I think that potentially that it could be helpful, but we would have to, take a look at your symptoms and talk with you about your imaging and your physical exam to see if that would be an option.
Okay. Michael's asking, saying, I have a spinal cord stimulator that I have had for 2 years now. Is this one that you were referring to that helps with the diabetic neuropathy? If not, can it be easily updated or changed without changing the leads?
So that is the brand that came out with the 12-month data. So there are some different programming parameters that can be done to try to target the lower extremities and the feet for that. And fortunately, it's with the same lead configuration that we would use to try to get control of low back pain.
The last question is asking if you'll be speaking about ALIF at the next webinar.
That is a great question. I know the next.
I won't be speaking.
Neither of us will be. We are not your ALIF experts, but our surgical partners will kind of be rotating the quarterly webinars. And so our surgical partners will be talking at the next webinar. And I don't know off the top of my head what it's going to be about, but I would encourage you to, you can go onto our website under patient education. You can see our first newsletter. And then every month we'll kind of tell you what's coming up for the next webinar. And you can kind of click on that link and register for that. But I do know that ALIF will be one topic of one of our newsletters too. So if you go there, click on that, sign up. If you're a patient of ours and we have your email, you'll get an automatic email link to that every time. We don't require a referral to be seen at Access Spine Center. So if you would like to be seen by us, we would just encourage you to give us a call, 208-457-4208, and we can get you in for an evaluation and see if we can help. And with that, thank you very much for joining us. Have a wonderful evening.
Thank you.